Thanks everyone for tuning in. This is the Para Podcast, and we are excited today. This is one of my favorite episodes, as Elias will laugh at me and say, all of them are my favorite. Anyway, as usual, I am Amadu Semtetwa, and I have Elias Thomas there in the corner, and Tulani Sibanda. We're all in different countries, and we have a special guest today, a man that I respect a lot. He was an HOD when I was at uni, so you must understand the respect that I share with this man. And also, if you hear me calling him Sir, Mr. and all that, do not mind. He gave me permission to call him Raveen. His name is Raveen Naidoo. And I have a lot of respect for him. I believe, Sir, you are now a doctor.
Yes, Malusi, and thank you and greetings to you, Tulani and Elias. It's absolutely a pleasure for me to meet with all of you again after many years. And you're quite right. I recently graduated with my Doctor of Philosophy, PhD, in Emergency Medicine at the University of Cape Town. So I'm quite thrilled about that. It's taken me a long time. Work pressures and all of the life happens. And so it does take a little bit of time. But I think, the divine will lead you and give you what you need at the right time. So I'm quite glad to have completed my PhD in emergency medicine.
Look, I think for me, a PhD means a lot, but I think you have achieved quite a lot. I remember as a student at the DOT, you were an HOD there. I think we used to know that you were working hard and you are researching. Research didn't make much sense then in our heads as students. We knew that that man there that is walking over there is a very serious man and he is on a mission. We would see it even the way that you walked, the way that you spoke, the confidence that you demanded when you were talking to us, and the way that you also told us to actually hang ourselves at university. I still remember that clearly. I'm not sure if you remember. I thought I'm going to share this story. There is a point where you came to me. It was at Ritson campus. It was in front of Videotech. Those that know DUT would remember. I'm not sure if you remember that. And I was sitting there in the benches. I was going through a bit of a hard time at that time. You came to me and then you told me how much you believed in me. And you told me that you see the way that I work hard. I have so much potential. And you also told me, give me guidance in terms of the career, how I should tailor it at that time. And I did exactly that. I think what the two things that I remember is that you called me by name, yet I was a minor student, one of first years or whatever, second years, I don't remember. And then you also told me about my capabilities. You knew about me and you knew of the things that I've done. So I do appreciate that. And I must acknowledge, I believe that if it wasn't for those moments, I wouldn't be where I am today. And I'd like to thank you.
It's an absolute pleasure, Malusi. And, uh, I've always had the approach that if you want to change the way people think and you want to improve the economy, you want to improve people's homes, you want to improve their lives, it's going to be through education. And when I got to the university, one of the things that I noticed, and I think if you look at the way universities were at one stage, the teacher will come and teach or the lecturer will come and teach. Whether you learnt or not was not their business. They felt they delivered the message and they go away. And I couldn't reconcile that thinking. I could not understand why people would do that because my mother always encouraged us to study. She used to tell us, you could take away anything from a person, but you can't take away their education. And so I saw that education was a way of empowerment beyond political empowerment and other people telling you what to do in that, but it's about your own self-enrichment. So when I first took over at the university, and it was one of my biggest achievements at that time, we had like a 3% cohort throughput in 4 years. And you can imagine if you start in a group of 30 in first year, only 3 will go through, or even less than that, will go through and pass the 3-year diploma. That time we were running 3-year diploma in 4 years. I mean, that was just appalling. I could never reconcile that. And so I used to also take the approach and say, I've been a student and I know what challenges I've been through to get there. I haven't come and was not born into a wealthy home. I was not born into affluence. whatever we had to work for. We had to live and live through it, find ways to make the best out of it. And so when the students, once I got into academia and into education and training and so on, which was my passion even while I was a student, I then said, how and what is it that I can do that's going to make a difference in the students' lives? You know, what is it that we can do? Bearing in mind that, you know, if you have a group of students, that's actually the best lot of students you've got. So students failing and having 80% of the class failing, and that was just not acceptable to me. And it was beyond this about delivery of academia and just an assessment, which many times the assessment methodologies are flawed and we're not conducive to the type of students that we have and so on. And I used to tell my class, and I think you might recall this, that when I would address the first year students, we have 30, 34, 36 people. Every single person comes from a different background, academic background, educational background, language, cultural, racial background. And we expect everybody to just gel and expect to know what is going on and how you need to do it and what you need to do. But then we are also, the other one that I really was quite strong on was about life skills. Because we would have people come from deep rural areas who's never seen a fully fledged library, has never been into an urban setting, and now it's a completely different environment. Come from environments where the go-go's kept the money under the mattress and then give that same student a thick stack of money to be able to manage in an environment that's got so many other challenges and so on. So those were some of the things. And then we would give students assignments, say, go do this assignment. But we never taught the students how to use the library, how to reference, how to research, how to write academically. So we didn't address those critical issues that were essential to ensure success with the students. And so that's, Malusi, what you were talking about, your experience. I made it a point of learning about who my students are, what the names were. It was difficult when you come in as first years. There's so many students. It takes time as you get around, but you get to know the students, who you are, and how are you performing. I used to look at every single test, which most people didn't realize. I would look at the results. Why was it? Why did that happen? What were the issues? You'd not believe how many students I found in the system that had learning disabilities, that were dyslexic, and were just barely passing a subject or barely just about failing a subject. But just understanding that and recognizing that turned it around. And it's like yourself, when you're in academia, every one of us will go through the program at some stage, and there will be a subject or a module that is challenging. There will be life issues that are taking place. I'll give you an example. There was a student that came to me on a Friday afternoon to say, Mr. Naidu, then I cannot write the examination on Monday. And my first response, because I was very hard on my students, and I'll never apologize for that. You know that. I would push, and I'll push hard, not because I wanted to make your life difficult, because I wanted you to succeed. And I would watch that. So the student came to me and said, I'm not going to write the exam on Monday. And my first response was, oh, you're asking for trouble now. Why do you even come to me and say you don't want to write? You got the weekend to study. So when I calmed down immediately in my mind, I said, okay, so what is the problem? I gave him a hearing. He says, my home burnt down. All my textbooks and all my clothing, everything burnt in that fire. And I probed further, and I couldn't believe the circumstances the student was living in and the challenges that they were facing at that time. So my immediate response was, let's get this examination deferred and then help the student with basics like clothing, food, textbooks, and that. That very same student passed completely, succeeded brilliantly, all right? With just a simple intervention of me contacting the other department and saying, look, we need to do something different. We have to grant a special examination. The student passed. When the student finished, and the student also had other challenges, NSFAS, you have to pass certain percentage of your subjects in the one year. When you get to the next year, You got to be able to access it. You got to pay X amount to be able to access it. I mean, you guys might know that better. And so the student didn't have the funds to be able to register, pay the registration fee. So we found ways and we raised the registration fee, paid it for the student. The very same student came back to me and said, "Thank you, Mr. Naidu," and said, "How can I pay it forward?" You know, and we talked about a student comes from a very disadvantaged background. And that was for me my concern, that if we're true and we were real and we're committed to transformation in this country, for me, it's not about capacitation and just workshops and just going about from one place to the other. It's about engaging with the material so that you change your thinking, you empower yourself through knowledge and academia, and then you will be able to hold your own and stand on your own 2 feet. Nobody will push you through. Nobody's going to massage you through any program or anything else. You work for it. And that was what my focus is. Give you the skills so that you are empowered to succeed in whatever it is you do. And then knowing when our students have problems and challenges in it, and you can see when they are having problems, and you already know it, you just make that little bit of intervention, a little step. How are you? Are you okay? What can we do to help you and support you? Is there anything else that can happen? Yes, it gave us a lot more work, but look at the results of that. You know, look at the outputs. And that's where I say, if I scold a student today, don't judge me by that. Look at what has been the result as a result of all of those interventions and what difference has it made to that person as an individual and then the families. Because for me, when I first started, I wanted to be a paramedic on this. Response unit, the lights and sirens, and it's quite exciting. That's how all of us start, isn't that so? We're young. We see that. But the bigger picture is, what is your contribution to society? How do we improve our socioeconomic situation? And it's not just for us, it's for the entire country, wherever you are. How do you improve your lives there? Because if you go to if any of our graduates pass and they get a job, then at least 10 people in their family move above the poverty line. Those are the deeper thinking, and those are the things that drove me. And especially with what my mother used to always say. We may be poor today, we may not have this, but you can study, you work hard, and you will see the difference from that. And you've said that now, from being operational, from being on the road, functioning on ambulances in the various areas and so on, then knowing that I want to go into education and training because I believe that you can change that. And so from the 3% cohort throughput, by the time I left the university, we were in excess of 90% cohort throughput in 3 years. And then we were changing over to the bachelor's degree. That for me was the success. And that is what I'm always will take back with me, and I can rest easily when I put my head on the pillow and say, I know I've done a good job, if I may.
It's a mouthful.
Did you not say something, Elias?
No, you go for it. I have a few questions, but I think I'll reserve them for later.
Okay. Look, my next question was going to be, what, as a leader at university, what was your biggest achievement? Okay, I understand in terms of the through output, and I am aware during the period that I was there was that new course that was starting out. It was called BTEC at that time. And what was your involvement in that? And how did you feel afterwards, after it was implemented as a course? And what steps did you take to get to that?
So we were stuck because once we did the 3-year national diploma, that was it. That was like the ceiling at that stage. And you are taking me back in time, Malusi, because the BTEC program, I'm very happy to say, along with the Masters, the Bachelor of Health Sciences, as well as the PhD in Emergency Medical Care, if you want to know what were my highlights, those were it, because I drove and was instrumental in initiating all of those programs within the country. And
Salute.
apart from the very first diploma program, I've been involved in the curriculation of all the subsequent programs, including the 1-year higher certificate, the 2-year diplomas that came out. So I would say overall, I've been very blessed to have had that opportunity to be part of that academic growth and the development of our profession academically. So to get the BTEC off the ground was an extremely big challenge. Because remember, at that point in time, we were a very doctor-led profession. We practice under the scope of practice, under the licenses of the doctors, and then we would report to the doctors as we go along. So we said we needed to get the growth of our profession. We need to get to postgraduate studies because research was minuscule, like a drop in the ocean at that stage. Very few papers were being published within the country, and just globally, it was still a profession that was still growing. But in first world countries, they were far ahead. And so we needed more research within our country. But to do research, you have to learn how to do research. It's not something you just thumb suck. It's like, how do you do an assignment of referencing? Now we can talk about Harvard and Chicago and all the different methods, and you've got referencing tools. Those days you didn't have that. You just took things off the internet and you plagiarized what you could when the internet came in, and we were doing that. That's the reality. You find whatever textbooks. Why are you smiling? Because you know you did that when you were a student. That's the reality.
There was no turning in, I think.
Those were not admissions, are you saying that? Yeah. So we said, yes, we need to do that. And so the research methodology was mandatory to be part of the BTEC program, the fourth year add-on program. And it was BTEC because it was Technikon Natal and Technikon Witwatersrand were the only higher education institutions offering this program. So two of us. The others were, they said, we need to put something in management into the program, which we did, and something about educational techniques because we need to learn how to teach. And we make assumptions that we all can teach if we got a qualification, but that's not the case. You know that. A good clinician is not necessarily a good manager or a good teacher, and the vice versa may also apply. A good teacher is not necessarily a good clinician, and a manager is not necessarily a good clinician. But we started as clinicians, and that's what we were focusing on. When I had approached my management at that time, they said, I'm trying to create an elitist group of people. And I said, but this is academic progression. You got to allow the profession to grow by qualification. And while we have the short course system and so on, how do we get to the next stage? Through some clever means of engaging with people that would support it, we then submitted that qualification through Technikon Natal then, and we then got the BTEC off the ground. The very first program, we had to pilot it. The EMC for the research and that all of us that were lecturers at the time, all we had was a 3-year national diploma. So we became we were lecturers, and then we became the first cohort to go through that, and including our colleagues at Technical at that stage. And then as we did that, some of us had gone on to doing postgraduate studies in education. We still couldn't get towards masters and doctorates at that point in time. And there's a few of us that were looking and we're keen to do our masters. But I'll be quite honest, at that time it sounded like, sexy title, nice to do a master's and feels good about it. But we didn't really fully understand. Yeah, it's still sexy. I'll take that. And so there were a few people that went overseas and did their PhDs. Some went off to do master's qualification. Some went to do masters. Some went to do masters in education and so on, because we didn't have that vertical option. And so we said we need to create that. That also became a problem because as I tried to pursue that within this country, I was laughed at by very senior academics said, but you're an ambulance driver. Why do you want to do a master's degree? And of course, that got my blood pressure up and I stood my ground and I said, sorry, that means you don't understand what we do as a profession. This is the level at which our qualification is. We are at Technikons, but I can tell you arguably that we should, if you want to have a differentiation between a Technikon and a traditional university, we should be at a university, because we are doing anatomy, we're doing physiology, we're doing pharmacology, all this physics and chemistry. It's equitable to all other universities that are out there. So why is it that, because, there's some technological aspects of that, but you can argue that now. Every program's got that level of technology and so on. What makes us different, So, and why couldn't we go ahead? So that's how I started to embark the process of going to do my master's. I did my first master's in University of Brighton in the UK, MSc in cardiology. And then at the same time, started the process of getting a master's in emergency medical care approved at DUT. And we were also I was working very closely with Prof. Lee Wallace at University of Cape Town. Because at that time, we were talking about 2006, 2007, that he was working on the master's in emergency medicine, the degree in emergency medicine. And we said, right, let's support each other. So let's work together. Prof. Wallace and the team, Prof. Bricevich from University of Natal, then Dr. Linda Granger. We formed the academic team, and that's how we started the master's program. I had already started the paperwork for the PhD in emergency medicine because just thinking ahead, and I said, we're not going to stop there. We need to move with this. But we used that document to also get the PhD in health sciences off the ground at DUT. So that became a basis. So we worked with some other of the colleagues at DUT, and we got the PhD in emergency medical care off the ground. But even there, too, the PhD in emergency medical care was still going to take time. We needed to build a faculty around to support that and to grow the program and develop the programs and so on. So, and that's how, we started working across, again, the emergency medicine discipline, and that's how we got the profession off the ground. And then he also had PhD in emergency medicine taking off the ground. So it's been a long, long journey. It's not an easy journey, as you can imagine. Lots of obstacles. Now I see people very young going straight into their masters and their PhDs, and it's almost like a rite of passage in that. And I think to myself, I wonder if they even think about the challenges and the difficulties that we experienced. There are people like Lloyd Christopher and myself. We've worked in the profession, growing and developing aspects of it. We put our own postgraduate studies on hold, to build this pathway and to create a system of growth academically for everybody that's in the profession. So my personal belief and feeling is if you can pass first year to university, then you have the capacity to finish your PhD if you desire it. All right? Because it's a lot of work. It's up to you to say, right, I've reached the level that I want to, and I'm prepared to stop here for my own personal reasons, but the system does not stop you and does not hold you back.
Now, you are in a very key position now. We're taking it to the next level. So I believe you are the National Director of Emergency Medical Services and Disaster. Is that correct? Yeah, disaster
medicine. Disaster medicine.
You there?
How long is a piece of string, Malusi? So, look, our role is mainly on the oversight, policy implementation, regulation, setting standards for emergency medical services in the country. On the disaster medicine side of things, it is to provide emergency medical services and to oversee the EMS provision at disasters and look at some of the systems there and on major events that take place. We have G20 at the moment. It's a major program, international program. So there's multiple meetings, activities taking place. So then we would then look at that system and making sure EMS provided at all of those. Other big events, like if you look at the presidential inauguration, more than 50,000, 55,000 people, and then ensuring that you have medical provision for a big single event for limited time at that point in time, and so on. So you have a number of those type of activities. There's lots of other work in terms of, that needs to be done for disasters, even on the ground response. And there's times that, we don't just sit in the office. We go out to scene and we go and assist and do as much as we can, where it is possible to do so. On the EMS side of things is, one of my first tasks was to respond to the then NHI white paper, which said, that we needed to have regulations, policies, and SOPs and seminal documents to guide EMS provision in the country. We also then need to look at implementation of the 3-digit emergency number 112. Then there were other aspects about getting a uniform service because, in South Africa, we have the National Department of Health and the 9 provinces. And the provinces are quite autonomous in various, especially financially and so on, and in their systems across the health and across many of the sector departments as well. And so EMS did not have a uniform system. Every province, in terms of the public sector, would have their own leverage on the ambulances and the response vehicles, their own logos. The uniforms were different. The ranking structure was different. So all of those were things that needed to be addressed. And so we responded to that because the idea would be to create almost like a uniform system service, an equitable service, and a good quality service. And with being within government and in terms of our constitutional responsibility, Section 27, we have to respond to emergencies. Every person has a right to emergency care, and that is the role that we provide as government. So it's within that framework that we do a lot of these type of activities, and this is what we engage with all the time. As you get like now, our immediate priority is to review the EMS regulations were promulgated in early December or the 1st of December 2017, review the NESET policy, the National Emergency Care Education and Training Policy. We also put out the regulations relating to standards for emergency medical services, like the way you have standards for clinics and for hospitals. Now we are working on a regulation relating to governance of EMS, because that seems to be a challenge within the country and to show the structures that we need. We have also working on a policy regarding planned patient transport. And then there's a number of enhancing activities that we engage in at various levels. Within the provinces, because we can't function without the provinces, we work together very well. We're very challenged because, we are tough personalities in EMS. Most of us are type A. I don't need to, you see Elias is smiling. He knows what I'm talking about.
It's true, yeah, it's true. Everywhere,
Yeah.
Yeah,
everywhere.
So first of all, I just want to say, the first time I met you, I think it was 2014, 2015 there. I had applied for a master's at DUT, and then I got accepted, and it was still your tenure as the HO department, as the head of department in that space. And I think when I embarked on the PhD, on the master's at that time, I didn't know what I was getting myself into. I just wanted to do a master's so that I can further myself. But as years went by, I got to understand the value of what a PhD means. It's not just a simple of doing research. But I think during that time while you were there, from someone who's done a BTEC to a master's, there was a lot of introduction to research methodologies. The way the whole program was designed in terms of equipping us to be able to function as a person that is doing research. Are you able to do research as an independent researcher? Obviously, you've got supervisors that guide you, and my supervisor was Degma and with another person. But I think the whole program, the way it was done at that time, was brilliant. And you being there and the work that you've done, we don't know about this. There's something that I want to say before I ask my question, is that these are untold stories that nobody will never know about. And I'm glad, and I thank you for coming to this platform to share those stories. I mean, when you look at the NESET policy, I think people that don't know about the NESET policy, the National Emergency Care Education and Training Policy in South Africa, which aims to transform the emergency medical care services in terms of education and qualified personnel. That's a good policy that exists there that people should read. But we don't know who drafts those policies, who's responsible for that. But I don't want to divulge. I just want to go back to what you've said as your role as part of the national director of EMS, is that in the emergency medical, in the healthcare, there's presidential talks that are being held. We hear them talking about their national insurance bill that is going to be introduced. And part of it, when they make those public presentations, announcements or briefing, I've never heard, and I'm just being honest, because even though I'm not in South Africa, but I do listen to what's happening in SA so that I can know, because indirectly or directly it affects me. They don't mention any of the emergency medical services and what role do we play as emergency medical services. And we don't know if the EMS is part of the planning. Now, from a director's perspective, I wrote this question down, is that what role Can you please share some light on the strategic role and visions for paramedics and the broader aspects of pre-hospital setting within the NHI framework, and what role do we play and how do we form as part of that? I think it's important that we have that voice, especially from you, because as I mentioned earlier, even the president himself, he speaks about the doctors, the nurses, but we are an essential service that when we get called, we are there in the front line. So yeah, that's my question.
Chalani is a very good question. And even though it's not mentioned, it does not mean that EMS is not part of it. Remember, I mentioned already the NHI white paper. It was a white paper, it goes through various processes. Their EMS was already mentioned at that stage. And those are the key components that I mentioned of what we need to do, including the interface between pre-hospital and the in-hospital environment, the emergency medicine side of things, and looking at how we breach that. So we have already responded to that, because implementation of the NHI is not a one-hit wonder where you put a switch on and then NHI is going to be there. Remember what the NHI is all about. NHI is a funding mechanism. It's not a change in the healthcare system. It's a change in the way that we fund the clinical services and how providers can be accredited to be part of that, and so on. And what is NHI trying to achieve? If you look at what you'll hear my current minister talk about, universal health coverage. So what is universal health coverage? It's about equitable, quality healthcare services without financial, without causing any unnecessary financial harm or
strain,
distress to the patient that is out there. Okay, and so going back to that now, coming back to that aspect, because we know we want equitable service. And that's why if you think about EMS and what it is that we do, we take healthcare to the patient at the point of injury and illness. All other patients will self-present to a healthcare facility, and they should not be denied emergency service when they get to the healthcare facility. They should be given quality healthcare services when they get to a clinic, a CSC, or get to the hospital. And so EMS then will take healthcare to the patient, achieving what we would call universal health coverage, because we now, and I'd like to believe that we provide quality services, but that again is, depending on the type of services and the resources and so on. And so therefore, in order to offer quality services, there has to be a minimum skill set. There has to be rules and regulations for you to be a provider. There's got to be equipment in that to be able to provide it. And we've responded already. That's where the EMS regulations come in. Okay. Mm-hmm. Now we want to talk about the standards, and that's where the standards regulations come in. When we want to look at quality care, you've got to have somebody that's appropriately trained, has quality training, and it is training that is equitable and can be assessed across the world. And that's why we moved from the previous short course system to higher education system. You've been part of education, so you understand why the training needs to be realigned with the National Qualification Framework and how it allows for the lifelong learning process and recognition of prior learning and the accreditation processes that go with it. So although it may not be mentioned directly by the president or the minister or in other fora, remember that EMS, public EMS in the country, for me, is an integral component of the healthcare system. And where do you see that? When did we see that? All of us have been through COVID. And you saw the collapse of hospitals because of limited resources and facilities there. But what is it? And just simply because of the overwhelming needs of patients, and we could not cope with that. But EMS then played its role, and especially our public sector, where we then took those patients from that facility to another facility. Mm-hmm. And showed the integral role and the critical role that EMS played. Now, where we're talking about high flow oxygenation, we talked about infection control, we talked about ventilation of the patients. We were already trained in all of those aspects. We may not have had high flow devices, oxygen delivery devices. We already were trained in use of ventilators and managing of patients there. And then we already were au fait with infection prevention control techniques and skills simply because that's what we do every day of our lives. When you go out to a patient, you don't know that they have a contagious disease, right? But we can't deny them care. So we go there, we put on our PPE, whether it's gloves and masks and combination thereof, or gowns and that, and then we take the necessary steps moving forward on that. Okay, so those are things that we got to reflect on. Now, if you look at NHI, and I'm coming back to that, it's a funding model. In this country, what is it? It's a national health insurance. You guys are now working in that environment. You've seen what the NHI can do. And what it does, it allows equitable access to healthcare systems. So nobody will get denied on the basis of the inability to pay for healthcare. You know, everybody then will have the same access. We control the fees that are being paid. So for EMS, we've already implemented those systems and we already are quite far ahead. In fact, EMS is low hanging fruit when it comes to NHI implementation because our fees are standardized. We do need to review that. I agree. We already have an accreditation process of all of the services that are out there. Many of them, and I was looking at KwaZulu-Natal data just now before this, we've got a distribution across rural provinces. We've got a higher concentration in urban settings, and that we got to accept by 2050, 50 in the world, 80% of the population will live in urban settings. You know, we are already working on we've been working on this for a period of time and change of the educational systems, and more people are coming through. There are implementation challenges. There are issues that we need to deal with. And that is what we will keep fixing. Because as you implement something, there will be things that happen that you didn't envisage. You couldn't see those. But as it gets implemented, say, okay, oh, wait a minute. What was I thinking here? Was I smoking something nice at that time? That I need to make changes now. You have a certain vision and you see it doesn't pan out, then you correct yourself and you keep moving forward. So under NHI, I think that we've, while it may not be mentioned, it was in the NHI white paper. We've already addressed a number of those issues. There's work that we're doing now, which is now revising the EMS regulations. We're revising the NESET policy. We're also revising the fee structure. We're starting a lot. That is something that's going to be starting now with our NHI teams that are there. And then we also then need to look at what would be the models in which we engage with all services. And so there are providers within a certain geographical area. And then how do you pay for those services as we move? And that means that the person or a member of a citizen of the country or a member of the public that is in a particular area, if they need that service, they will not be denied because they don't have money to pay. And when they do get that service, we will get good quality, effective services.
So for me, I think, just to comment a little bit, look, I think it's important what you've just highlighted, because you mentioned quite a lot that the work is being done, but what was exactly being done and what was not being mentioned from the ministers or the government is what you've just said now. And a lot of the people in emergency medical services probably had the same question to say, okay, where do we fit in this place and what is the work that is being done? And thanks for that, for highlighting that.
Yeah, I think, Tulani, just to close that a little bit, you're quite right. More needs to be said. And I think it was Malusi that also talked about the research and getting these experiences out and so on. You're quite right. More needs to be done. It's a challenge because we need to bring more people on board, guys like yourselves, to create this platform and to take that baton forward, and say, right, let's now write a position paper on this. Let's look at how we can publish more about this and look at our responses on them. For us, you engage in your day-to-day activities. Yes, we will publish. We will get papers out and that. But how do we proliferate that? How do we get more and more of that information out? The thing is that you'll find that it'll never be enough. That's the reality. Yep. And remember, EMS, we've always been the stepchild or the dislocated arm of the body. We are drivers. Nobody sees us as professionals.
Ambulance driver.
Sometimes we don't behave like professionals. That's a reality.
True.
So we need to change the discourse. It's not about somebody else changing the discourse for us. Yeah. It's about we are the agents of change, and we are the ones that's going to promote our profession. No one else is going to do it for us. And that's what I always say. When the doctors were in charge and we practiced out the scope of their licenses, we had a very controlled service. There was a lot of quality assurance, and we have managed that. But when we became independent practitioners, we were excited. We threw parties about that. But what did we do? We threw the baby out with the bathwater. There were lots of good practices that were there that we didn't take up. And we also didn't, I think that we had to grow in the profession to get to where we are now, to say, yes, we are in charge now. We don't like this. We don't like poor management of patients. We don't like untoward behavior towards our patients. And what can we do to promote research? What can we do to promote academia? And how can we get more people within the profession to get to the points of high levels of qualification? And how can those people, once they get there, pay it forward? How can they now say, let's now pick this up and say, what else can we do? What are the gaps in here? And pick up with the gaps and run with it.
Yeah. There's a speech that you gave when I was doing my last year at university. I can't remember exactly what you said, but you pulled up your laptop, you spoke, and you spoke about the previous dispensation of the housing. I think you spoke about Umlazi and Chatsworth, and you said that, I remember that the context was that there is literally one road that enters until the end. And it was because of how the houses were designed by the apartheid system and stuff like that. I actually appreciated the way that you made that speech. My mind was just surprised because you spoke about something that is so sensitive in South Africa, but at the same time, we're very comfortable to talk about it and listen to it, and it made sense. Now, that tells me about your heart with the people of South Africa and your stances around the socio-economic status of the people. Now, my question in that will be, Mamutul Madonsele used to talk about Goku Dlamini. Goku Dlamini lives very far from the city, about 50 kilometers from the main town. Goku Dlamini wants an ambulance. She calls an ambulance doesn't arrive in like 6 hours or never arrives at all. Or they say, no, Goku Dlamini, you're too old. We can't bring an ambulance to you or something like that. How does the system that currently exists checks those things like that? How does Goku Dlamini say, we have a crisis here, I can't get an ambulance, because Goku Dlamini doesn't know? Or how does the system itself checks itself that these things are done and they should happen as they should?
So Malusi, there's, from a national point of view and in each province, we have what we call indicated data sets, national indicated data sets. One of the things that we measure in each province, each district, is what is our response time to priority 1 calls in under 30 minutes, what percentage? Then similarly, we do what is our percentage of priority 1 calls in rural settings, in under 60 minutes. So those are some of the measures that indicated data sets are looking at how we are performing there. It leaves out all the other patients, and that's a concern. But one of our biggest challenges is that we hamstrung by budgets and funding, because I would like to see that all of that information that you talk about, where we measure our performances in that, be a single or a computer-aided dispatch system that collects all of this data live and gives us performance reports live. And so then you start to manage and look at how effective our performance is. By doing it like that, we will also be able to know what our resources are and where our resources are located, what is the demand, and where the demand is, be able to respond accordingly. So until we get to that point and use the technology within our own country, we're going to be challenged and in terms of our overall performance. Many times people will ask me, or I will say to them, if you tell me I'm going to get a whole lot of money, millions or billions of rands for EMS, what would you do first? They'll say, you buy more ambulances. I said, no, I won't buy ambulances first. I'll buy a dispatch system that will give me live performance monitoring against the resources, against the demand first. And when I got that, that'll tell me how I'm using my existing resources. Am I effectively managing my existing resources in terms of ambulances, responses, helicopters, planned patient transport? And then I would match that against the demand. That will tell me if I'm not within certain time frames, that means I need to put additional resources. That's when we start buying resources, and then you start adjusting yourself. So your point is your question has multiple aspects to it. Rural areas are a challenge. Now, you take Northern Cape. That is a completely rural province. It's got the smallest population and very sparsely distributed. That problem that we face in Northern Cape is not unique to just Northern Cape. Every province has got that to some extent. And many countries in Africa and other places in the world have the same similar challenges, because response times will be a problem in rural areas, and it's well documented. So apart from response times in rural areas, prolonged response times, you've got poor road infrastructure. That's going to affect that as well. Then if you've got poor weather patterns in that, it's going to affect your response times. But that still doesn't solve the problem that Gogo does need to get an ambulance. Now, if Gogo is being told you cannot get one because there's none available, then that's a problem. Okay? We may be able to say to Gogo, we do not have any ambulances available right now, but as soon as we get an ambulance available, we will dispatch that to you. And that will affect our response time. But we cannot tell Gogo that we cannot deny Gogo an ambulance at all. That is not acceptable. And there are people that do these things, and we deal with those. That's a separate issue altogether. So when I travel through the provinces, and you go deep rural in Eastern Cape or any other province, as I'm driving, I think to myself, so how can you get a response time that is clinically sound? Now, in cardiac arrest, 7 minutes and 59 seconds. Am I right? You've got to be there within that period of time to be able to see that you've, in first world countries, used that time frame, 7 minutes and 59 seconds to get to the patient. Other places in the world, its response time is about 3 minutes. But then you go to other areas, it's like 29 minutes and so on. So there's such a wide range. And so you then got to split and say, okay, there are time-critical patients, and are we able to reach those time-critical patients in the time frames that are required? It's very difficult. Very, very difficult, unless you are in a first world situation. But in rural areas or even urban settings, then you say, where we know low to middle income countries, you've got limited resources. So the idea would be to do the best you can with the little resources that you can, and optimize that usage of the limited resources. It is not a good pill to swallow, because everybody, even the person that's got a fractured toe, is in extreme pain. That is an emergency for that person. For you and I, that's not an emergency. Okay? And that's a harsh reality. But every person does need care, and they need to get it timelessly. But it's extremely difficult when you have very limited budgets and limited resources.
Yeah, Elias.
Yeah, I think I just have two questions. I think one is going to be local, and the second one is going to be a little bit international in the sense of the African setting. First one being that I know that on the podcast, when you have chat to most South Africans, we know that retention in the country is a bit of an issue. Quality paramedics, don't get me wrong, but retention seems to be an issue. And one of those seems to be that safety is a concern. So I just wanted to get your thoughts at a national level, sort of like what plans do you have in the pipeline to address this concern? And then I think the second one would just be in terms of South African EMS is sort of like a big brother to the rest of Southern African countries, as most of the lecturers are usually from South Africa that start up these programs. And now one of the trends that we are seeing in most countries, and I can relate this to Namibia as well, is that the government aspect of ambulances or fleets are just, most of them are doing either inter-hospital transfers with nurses on board. What would your advice be to, especially to other national directors of EMS that are trying to run the system and ensure that we get the paramedics on board? Because as I know in Namibia, paramedics are not an issue. We are producing them, or they are producing them, but most of them tend to go out because if you can't work for private, you can be employed international. So you're losing the resources that you need in a country. And it's not only in Namibia. I think it's the same in Botswana. I think it's the same in Zimbabwe, and it's pretty much everywhere. What would your advice be in that sense? So those two questions would be mine.
Okay, on the safety side of things, it's quite unfortunate that EMS, which is out there to protect the public, to serve the public, they get attacked. But when we've done analysis, just to give you some idea, when we've looked at the why that actually happens, it's opportunistic crime. And it's related to the poor socioeconomic situation that we have in the country. The highest incidence is usually we found in the Western Cape. It's related to gang violence. It's related to substance abuse. It's related to areas where there's low lighting, poor visibility, poor communities, and so on. And so people then will look at EMS as a potential resource, steal what the contents of that, hold up the crew and take the personal items and so on. And, under no circumstances do we condone it because of those reasons. EMS is a resource for the community when they need it most, and so they need to be protected. So there's a number of interventions that need to be done. At the national, we work very closely with all of the provinces, and we've looked at, there's 4 focus areas. The first focus area is on the crew, on the personnel. The second is on the management of when these incidents happen. How do you manage that? The third focus is on technology and the use of technology. And the last focus is on the community. Now, the greatest and the most beneficial intervention was with the community. Nothing else but the community. Because remember, EMS is serving that community. So you have to engage with the community leaders, the policing forums, the community policing forum, any of the other structures that occur that I have within the particular district or sub-district or that community, and engage at that level, because you need to impress upon the people in that community that if you take ambulance, we're going to withdraw the services because the safety of the crew is of paramount importance. We always teach hazards, hello, help, the 3 H's approach them. If going to a particular area is hazardous for you, then we can't send crew there. That's the reality. But that's the last resort. Because in that same community, there are other people that need help. So you can't deny somebody else assistance because one person or a few people are doing that. So you have to engage with the community. And we found that made a big difference, a huge difference. Then the techs, like I say, there's the technology using panic devices where you can afford it, using the onboard cameras, knowing and working very closely with SAPS. We have what we call a NatJoc instructions from ProvJocs, the provinces, where NatJoc, because we set up a EMS safety priority committee at NatJoints that's responsible for safety and security of the country. And so there was an instruction went out to the provinces that when EMS requires, SAPS will escort us into highly volatile communities and protect us and assist us with that. So that still is an ongoing activity. There are some challenges with that, like everything else. At the National Department of Health, we set up what we call the National EMS Safety Forum. We have representatives from every forum, every province focusing on being part of that forum. And we've got our own terms of reference. We've also got the National EMS Safety Plan. And those 4 focus areas are looked at, and it's constantly being worked on. Apart from that, whenever an incident happens, we get lots of media queries. And so that is responded all the way from the minister at times to our staff in the National Department of Health, then our staff at the provinces, as well as other individuals that may come out and denounce those activities. Especially we get good support from the political leadership and the technical leadership from within the provinces. So you've got to keep on denouncing that. We had an incident in Gauteng where through the technology that Gauteng EMS had implemented, we were able to locate the crew and the ambulance very quickly and be able to rescue them within a minimum period of time. It is extremely traumatic. It is frustrating because that's not why we are there. We're not there to be attacked. We are there to be respected and savored because we are there to save your lives, the community lives. We are there to provide healthcare at your point of injury and illness. So we need you to support us so that and the public to support us in order to give you better healthcare. So I hope that helps in the safety side of things.
Yeah.
Yeah.
So in the international scene, we're quite proud to say that a number of our graduates have moved on into Africa. And a number of our graduates are elsewhere in the world as well. And you know what? No matter what you do, Elias, there are push and there's pull factors to migration, right? You can read Kevin Governor's research. He did his master's on the push and pull factors on that. And so each and every one of us, all of us sitting on the call, we have our own individual needs. And there are things that drive why we would want to leave the country, and there are things that would drive why you would want to come back into the country. And the market forces also dictate. If you went through your studies and you just barely made it financially, you depended on government grants. Your family is depending on you to educate other people within your family. You may be the first person that qualified in your family. When you go to graduation, you see the ululation, the excitement, and whole families come to your graduation for one person, maybe 10, 12, 15 people. And while others were saying, why so many people? You take a step back and you look at why. Because it's a huge achievement. It's a great achievement. It's a milestone that has been achieved, not only for you, but for your family. And when that person gets that job, you then help and you educate other people in your family. You help transfer that. And I must say, that's one of the things that, we've seen in certain population groups within our country, where the strong focus on education is what took people out of abject poverty. Educating yourself, getting better jobs, helping other people within the family by paying it forward within the family, and then you start to see the change. So when people leave our country and they go into other areas, and especially in low to middle income countries, that needs to be supported, that needs to be praised. And if there's any way that we can assist, it's not only just about South Africa. We have a responsibility within SADC regions. We have responsibilities within the African continent, because we are talking about a low to middle income settings. But at the same time, we must also acknowledge that people may have financial difficulties and the salaries may not be good enough within our own setting and may need to go out of the country. But I've seen people come back and work within the South African context again, But it's also okay, because you go and you learn about different systems. You look at different ways in which people do things elsewhere in the world. And what is it? When you come back, you're richer with experience and knowledge of different systems, and you add to the richness of what we do. You contribute to that. You say, but hey, hang on, we're not doing enough in terms of clinical governance in this country. We're not doing enough in terms of quality management. We are so antiquated in some of the medicines that we are using. We're still practicing in the old way of doing things. Why don't we change it? And that's good. All those are the good stories to be told. So, yes, it is a concern, but it's cyclical. We see this, that the moment we have a new set of graduates, they come out, they work within the country a year or 2 years, and then before you know it, they're either going to the private sector. But if you're going to the private sector, we still see you within the South African context. But once they as they grow and we get used to the system, you are young, very young. You're under 30 by that time. You still got a whole career ahead of you. So we hope that when you go out there, experience whatever it is, you bring it back to our country and you make our EMS a better EMS.
Yeah. I think that there was a part of the question by Elias that was talking to EMS directors in those countries, for example, in Namibia, with the people where people are leaving. What was your question, Elias?
Yeah, it's just with regards to where the ambulance is not yet, the government is not yet on board. What could possibly help this nation? Yeah, to help these national directors to get the ambulances up and running, like what the provincial government is doing in South Africa. What advice would you have to them? Because they might have the fleet, but they just do not have a system, and it's all just going to waste. Even though they might have bought all this fleet of ambulances, but it's necessary that doing inter-hospital transfers.
So from a South African perspective, because there has to be like a note verbal, there's a process. We cannot presume that the system is failing or it's weak or it's not optimum. We cannot presume that. So it's like very much like when we have a disaster in another country, within Africa or anywhere else, we cannot just force ourselves in there. There's got to be a request from the government of that particular country to the government of our country, and then we can assist in whatever way that the assistance is required, to the extent that we cannot implant our systems into another country, because healthcare needs are different, in different countries. So you've got to adjust and look at that. What are those needs? But it isn't something that we haven't done. We've worked with other countries in Africa. We've shared our legislation, our regulatory documents. So when the opportunities present at international fora like the AMSA conferences and so on, African AFM conferences, African Federation Emergency Medicine, we talk about our systems and we collaborate with our colleagues as we go from other countries in the continent. But most certainly, from a country perspective, we will never refuse to assist and provide any of our experiences. I won't say our, what we do is going to be perfect and our regulation is going to be perfect in another setting. But we will share what our experiences are so it can be adapted for their own particular circumstances.
Thank you.
I still have more questions, but we're running out of time.
Yeah.
So much to unpack. Yeah. But yeah, Melusi, over to you.
Yeah. Look, let us wrap up because of time. Look, if we're to talk about time right now, it's almost 1 a.m. where I am, and it's almost 5:30 in South Africa. In Qatar, it's after 6. New Zealand, what time is it? Is it 3?
So almost 3:30 in the morning. But yeah,
we can see it in Elias's eyes.
Yeah. So I think
but the conversation is going. It's absolutely amazing. It's a lot of wealth of knowledge and, things to learn from there.
Yeah.
I think that's one of the things that we've done. Sorry, Melusi, about that. I think one of the things that we've done on this podcast is the sacrifices that we've made just to make sure that we try and get, because sometimes I'll be coming from night shift, Elias will be coming from shift, we're tired, but we make sure that when we show up, we well prepared and we give our best. And time is always not on our side. That's been the challenge, but we try and make it work.
On that note, we highly appreciate your time, Dr. Raveen Naidoo. You have given us your time, the time that you'd be at home with your family, but you've given it to us. We highly appreciate that. It means a lot to us. We do hope that we have another opportunity sometime to talk to some other issues. There's so much to talk about that we have in mind. And I think you are the right person to talk to about. We are going to look at other people too, as you have suggested. We thank you, and I hope you have a great week and a great year ahead.
So thank you to you guys, because I must say that congratulations and kudos to you, because you've really done well by setting up this Para podcast. There's a lot to be learned from that. And I think that you are perfect examples of paying it forward and leading the profession. You are much younger than we are, but you haven't sat back and said, well, I've arrived and I'm just going to stop there. You're taking this forward. And I think that these type of conversations are good. Where do we go to from here? What's for me, these are my closing points, is that, what are the critical issues for within the country that we need to look at? Gone are the days when we only talk about what we're doing now. We must be looking at where do we see ourselves in 10 years' time? Where do we see the profession in 15, 20 years' time? Because then we won't be in the profession. But have we set the course right? Have we set the direction right? And I think that by you guys doing this, you are now helping the profession going forward. You are helping us set up a course, and you're creating a discussion platform that will be shared by others. And many others will read this much later and say, oh, wow, we talked about that then. We talked about this then. Some of these problems still exist. But look at where we are now. You didn't expect to hear about the difficulties that we had to go through to get the BTEC off the ground. Nobody knew that. Nobody knew what the challenges were to get what the masters and the PhDs off the ground. And those are just some of the issues. Some of the other challenges, like the safety that you've highlighted, the issues regarding clinical governance and so on. These are things that we need to look at, because we must focus on quality care. And we must look at how is it that we respond to the people that we serve. Everybody has a right to good clinical care and needs to be treated with dignity. And with that, I want to say thank you very much once again for giving me the opportunity. I'm very proud of you.
Thank you very much.
Thank you. You're welcome.